Great. Hello, everyone. Good morning, afternoon, evening, wherever you may be. My name is Michael Canary, and I'm a PICU doctor at Yale New Haven Children's Hospital in Connecticut, USA. And I'd like to welcome you to the WFPICCS Respiratory Chapter second monthly webinar, When Blood Meets Air, VQ Matching and Shunt Mysteries. For those of you who were able to attend our last session, I'm sure you'll agree that Dr. Martin Canaivo did a lot of great teaching, and we expect the same from Dr. Mema today. I'd like to take just a moment and introduce the rest of my distinguished panelists here today. Georgiana Pizamolis is a senior physiotherapist at Queensland Children's Hospital in Brisbane, Australia. Dr. Milind Jambagi is a head pediatric intensivist and ER services at Ankura Hospital for Women and Children in Puth, India. He's been a longtime member of the WFPICCS Educational Committee, is a former co-chair, and he's the current chairman of the committee, and has been instrumental in organizing traveling around the globe webinars. So that's quite an achievement. Our next panelist is Dr. Farhan Shaker. He's a lead intensivist at Rainbow Children's Hospital in Hyderabad, India. And finally, our colleague, Dr. Abdul Rahman Al-Denath, is a pediatric critical care senior specialist at Ahmadi Hospital in Kuwait City, Kuwait. I'd like to run through just a little bit of business before I turn it over to Dr. Abdul Rahman so he can continue introducing our distinguished speakers today. So we have an introduction. After this, we'll have a 30-minute lecture and then a 15-minute Q&A session. So throughout that period, you're welcome to use the chat function and post questions throughout the lecture. But please confirm that your microphone is muted. In addition, this lecture will be recorded and it will be available at the WFPICCS website. So we'd like to invite you to log into that and register, and then you can view not only this lecture, but previous lectures. We'd like to remind you that the convention, the WFPICCS convention, will be held at the end of September, the 26th to 30th, in Melbourne, Australia. And registration has begun. And I think if you want to make sure you can get a place, register early. And then finally, I'd like to do a little plug for our next session, which will be March 19th. And that will be looking at the lung as a spring, looking at issues of compliance, resistance, and work of breathing. And I'm sure that will be an excellent session as well. And that will be our guest for that session will be Dr. Villanueva. So I'd like to turn it over now to my colleague, Abdul Rahman, so he can introduce our speakers and get this going. Thank you very much.
Thank you, Dr. Michael. It's give me a great honor to introduce for you our presenters today. We have Dr. Briseida Mema. She's a staff physician in the Department of Critical Care Medicine at PRCCS Hospital and a professor of pediatric at the University of Toronto. Dr. Mema is the program director for the Pediatric Critical Care Medicine Training Program at the University of Toronto and the Associate Chief of Education for Pre-Operative Services at PRCCS. She has received several awards for teaching excellence as a trainee and faculty. She's the chair of a national simulation event for all pediatric critical care trainees, tactics, that is, stand for training and assessment of clinician in teams in intensive care through simulation. She was the recipient of the University of Toronto Medical Humanities Education Grant from year 2019 to 2025, and she leads a medical humanities curriculum for trainees and faculty in intensive care to support the lifelong journey of professional identity transformation. Dr. Mema is the director of the bronchoscopy program also, and the program director of Advanced Respiratory Fellowship at PRCCS Pediatric Critical Care Medicine. She has facilitated close to 100 workshops on faculty development internationally, nationally, and locally in topics of bronchoscopy simulation assessment and medical humanities. Adding to Dr. Mema, we have also Dr. Karthi is currently pursuing Advanced Respiratory Fellowship at the Hospital for Sick Kids, Toronto. He was trained in pediatric intensive care at postgraduate institution of medical education and research in Chandigarh, India, and at the Royal Children's Hospital, Melbourne. He holds a faculty position at the Postgraduate Institution of Medical Education and Research in Chandigarh, India. So without further ado, it's giving me a great honor to introduce our speakers. The mic is yours.
Thank you so much, Dr. Abdul Raham, and it's our absolute pleasure to be part of this webinar and be able to teach about when blood meets air. So a disclosure for me is that I do not do research in respiratory or respiratory physiology or mechanical ventilation. But I have been a clinician for close to 2 decades, and I love to teach about respiratory physiology. And I have learned a lot from my colleagues here at the Center for Mechanical Ventilation in Toronto, the Center for Excellence. And also, I'm very happy to share this with our inaugural Advanced Respiratory Fellow, Dr. Karthi Nallasamy. And of course, always happy to be involved with WFPICCS. And we at PRCCS are very happy that Jackie Young is going to be the new president, as she is one of our very own alumni that we're very proud of. And so, thank you. I thought of starting, you learned a bit about that, how I've received the medical humanities education grant and my love of art. So I thought I'd start with art here. And in the background is Renoir's painting called A Gust of Wind. And we always use the expression, a breath of fresh air. And there, I also put, for some that might like Walt Whitman, apart from his poem, A Song of Myself, where he actually speaks about breathing and my respiration and inspiration, the beating of my heart, the passing of blood and air through my lungs, the sniff of green leaves and dry leaves and of the shore and dark-colored sea rock and hay in the barn, the feeling of health, the full noon thrill, the song of me rising from bed and meeting the sun. And so his respiration and a feeling of full health, it's very important in this poem. The blood meeting air adequately or in a healthy relationship was noticed by the Scottish surgeon John Hunter, who did a lot of animal experiments in 18th century, where he wrote, "Where there is no circulation, there can be no lungs. For lungs are an apparatus for the air and blood to meet. As the lungs are to expose the blood to air, they are so constructed as to answer this purpose exactly." So during this presentation, Dr. Karthi and myself thought of constructing it in a way that talking a little bit about initial physiological descriptions, a bit about modern day application and physiological surrogates, and then go into some clinical cases to illustrate the practical use of dead space and shunt concept in daily medical practice, and then their role in optimizing patient management, since we're both clinicians. So many of you might be very, very familiar with this, but we thought of putting these slides to just go back to the first principle in physiology, because you know, how blood meets air is a little bit like relationships in the world. The relationship with both show adequately, and the relationships when one of them shows up and the other doesn't. And so ventilation and perfusion range all the way from unventilated alveoli to unperfused alveoli, with every gradation in between. So We're going to go a little bit through this because we're going to use some of this in some of the dead space calculation or the shunt fraction calculation that we're using later. So in the first one, we have an alveoli with the VQ of 0. So that's shunt. And the pressure of oxygen and CO2 in that alveoli is going to equilibrate with a mixed venous. So O2 of 40 and CO2 of 46. However, we have to keep in mind that that alveoli is not contributing to gas exchange, and such that pressure of oxygen and CO2 is not going to mix or is not going to come in the exhaled air. In the other one, we have one where VQ matching is more or less perfect. And in that one, the O2 and CO2 in the alveoli will be a little bit in a mixture of inspired air with a mixed venous, O2 and CO2. And at the very end, we have an alveoli of infinite VQ, which is that space ventilation. And in that alveoli, the pressure of oxygen and CO2 would equilibrate with that of the inspired air. And so many of you are very familiar with this, very comfortable with this. We thought of putting it here as a first principle that will help us to build on some of the other concepts. So we're going to start with dead space or the wasted ventilation. And so in this figure from Nann's Applied Respiratory Physiology, you have the different component of ventilation and the different component that makes the dead space. So one is apparatus or instrumental dead space. We have the anatomical dead space, the conducting airways. We have the alveolar dead space gas of those alveolar units that are ventilated but not perfused. And then we have the ideal alveolar gas from alveoli that are perfused and ventilated and have good VQ matching. This is again presented in this illustration from Sipuli and colleagues in Journal of Anesthesia, Analgesia, and Critical Care, and in a very late article in 2026. And again, we can see their apparatus or instrumental dead space, the conducting airway dead space, the alveolar dead space coming from the ones that are ventilated but not perfused, and the ones that have normal VQ matching. So then next, we want to spend some time with the dead space computation or the Bohr equation. Christian Bohr, not to be mistaken with Niels Bohr, the physicist who won Nobel Prize, published this in 1891. And so he rightly so calculated the tidal volume to be a composition of alveolar ventilation and dead space ventilation. And so then such the total CO2 and the tidal volume, which would be the volume times the fraction of excretion CO2 in the tidal volume, would be a combination of alveolar ventilation times the fraction of alveolar CO2 aided the dead space ventilation and the fraction of CO2 in the dead space. Now, while if we go to this equation, the tidal volume plus times the fraction of excretion of CO2, we will do a few things. First of all, in the dead space, the fraction of CO2 is 0. And so that part of the equation would be 0. And then the alveolar ventilation would be tidal volume minus the dead space volume. And so if we rearrange for people who are fond of algebra, I was, if we arrange and simplify the equation, and we go from the fractions of CO2 to partial pressures of CO2, then we will get an equation that is dead space over tidal volume is the pressure of alveolar CO2 minus the pressure of exhaled CO2 over the pressure of alveolar CO2. And now, in terms of how Bohr did it, for the pressure of exhaled CO2, he calculated and measured all the volume of an exhaled breath and all the CO2 concentration on the exhaled breath. And for the alveolar CO2, he measured the pressure of CO2 at the very end of an exhalation. So that is the Bohr's equation, kind of simple. But the pressure of alveolar CO2 is almost impossible to measure and is so dynamic and affected from so many regional distribution of the ventilation and the perfusion. And so Enghoff modified this in around 1938. But this was after the blood gas had been invented, the advent of blood gas measurement in 1920. And so with that invention of the blood gas, he substituted the unmeasurable pressure of our alveolar CO2 with the pressure of the arterial CO2, because under normal physiological condition, those two should equilibrate. There are some limitations that we are going to speak about, but despite those limitations, Enghoff's modification continues to be the most widely used method in clinical practice today because he made it feasible and able to calculate it for the clinician. So another modification, so let me actually go to some of the limitation that the Enghoff modification of that equation did, because, and one of them is the shunt contribution to the physiologic dead space measurement, because shunt not only increases the alveolar arterial oxygen difference, but will also affect the alveolar arterial CO2 difference, and thus is going to increase the calculated physiological dead space. And this happened because the alveolar space of the shunt compartment is gas that would be in equilibrium with a mixed venous gas and is not going to contribute to the exhaled gas mixture. And so if we remember that we're looking at the difference in between the expired CO2 and the arterial CO2, in this case, the expired might not change, but the arterial is changing a lot and is increasing. Now a very large shunt is required, and shunt-mediated contribution to the alveolar dead space calculation will be increased in any condition that will increase the mixed venous CO2. Now I will say that we're overestimating the dead space. That's okay in some aspects, because then the dead space calculation doesn't really become only a measure of dead space because it's overestimated, but it becomes more a measure of gas exchange efficiency. So another thing worth going over is the end-tidal CO2 curve, and this is a time curve, not a volumetric one. And the volumetric one, it's better. However, not all the ventilator can measure it, and it hasn't picked up a lot in clinical practice as feasible and practical. And so we usually use the end-tidal CO2. So many of you are very, very familiar with this, and there are 4 phases to the end-tidal CO2 time curve. And so phase 1 is the inspiration and also the exhalation from the conducting airway. And so considering there's no CO2, then you have a CO2 of 0. And then you have the second phase where you have fast uprise, where air expired from the alveoli is mixing with the conducting airway. Now, it's important to note that the phase 2 does not represent the beginning of exhalation. The exhalation has happened in phase 1 when the conducting airway exhale. And then we have the phase 3 that is a plateau, but the slope of that plateau is gonna depend mainly on the time constant of different regional units in the lung. And phase 4 is when the exhalation ends and the CO2 goes back to 0. Now, many times in the clinical practice, we use this as measuring the alveolar dead space. And so is PA CO2 minus end-tidal CO2 over PA CO2. There have been other dead space surrogates like ventilatory ratio that I have put it there, or a standardized minute ventilation, or just like we use AA gradient alveolar to expiratory CO2 gradients. And certainly more recently, there are CT measurements, MRI measurements, and also EIT measurements. Now we'll go from dead space to some of the cases. And this is a painting by Samantha French called Just Breathe. So let's start with ARDS. So in 2002, Nucton and his colleagues were one of the first to look at pulmonary dead space fraction as a risk factor for death in the acute respiratory distress syndrome. And they found that increasing dead space was a feature of early ARDS, and increased values were associated with increased risk of death. And they postulated that this was likely due to vascular injury. In 2003, Gattinoni and colleague looked at PCO2 and prompt positioning and looked at it as a predictive of improved outcome in ARDS. So what they found was that it was a strong association between the PaCO2 response and outcome, and they found no association with the PF. So they postulated that prompt positioning help oxygenation with a combination of things, such as increased elastance or of chest wall, recruitment of dorsal region associated with the recruitment of ventral regions, and blood flow redistribution. And a combination of this would give you improved oxygenation. However, in terms of PaCO2, in non-responder, the chest wall impairment, so the stiffness of the chest wall, which decreases the ventilation, will prevail over the recruitment. And in the PaCO2 responders, the recruitment and the increase in ventilation actually prevailed over the chest wall impairment. So it was not really the CO2 response, but was the pathophysiology of the patient that impacted the outcome, whether they would recruit or not. And in 2006, this experimental study in animals from Sweden, Goran Hedenstierna, looked at monitoring that space during recruitment and PEEP titration in experimental model, and found that alveolar dead space over the tidal volume, and the difference in between alveolar and end-tidal CO2 showed a very good correlation with PaO2 and normally aerated and non-aerated CT areas in animals. So we're going to go to some cases. So case one is an 18-year-old previously healthy male with ARDS due to pneumococcus. He has no other organ dysfunction, is sedated, paralyzed, and volume control. And I put some of the ventilation parameters there. Tidal volumes of 380, respiratory rate of 28, minute volume of 10.6, static compliance calculated at 38, a PIB of 14, plateau pressure of 24, a driving gradient of 10, and an end-tidal CO2 of 25. When we look at the blood gas, is a pH of 7.29, PaO2 of 75, PaCO2 of 57, an FiO2 of 1, and a PF ratio of 75. So when we calculate the alveolar dead space here is the PaCO2 of 57 minus end-tidal CO2 of 25, and over the PaCO2 of 57, we get a dead space of 0.56. Now, this is one that I want to highlight because the dead space here is overestimation. Karthi is going to go later over shunt fractions, but you can see from the blood gas analysis that with a PaO2 of 75 and a FiO2 of 1, that this patient has an increased shunt fraction. And we will have an overestimation of alveolar dead space here just because of the shunt and the increase of the PaCO2 because of the shunt. And while this is overestimating the alveolar dead space, this is still a very good indices to use as the disease progresses because it tells you about the issue with the gas exchange. Our case 2 is a 16-year-old girl previously healthy with ARDS from influenza. There was no other organ dysfunction, sedated and paralyzed, and volume control. So I put there some ventilation parameters, tidal volumes of 480, respiratory rate of 24, minute volume of 11.5, static compliance 48, a PIB of 12, plateau pressure of 22, a driving gradient of 10, and an end-tidal CO2 of 24. And the blood gas, we have a PaO2 of 95, PaCO2 of 48, and then an FiO2 of 0.65. The alveolar dead space here, calculated again, is 0.5. Now, day one, there is a recruitment done with sustained inflation. There was no hemodynamic instability, and the PIB is increased when the PIB was increased from 12 to 14. After this, the PaO2 was increased to 105. The PF ratio improved to 161. Compliance improved somehow, but PeCO2 and end-tidal CO2 remained unchanged, which means that the dead space was unchanged. While there are not a lot of evidence does not agree what would be a good recruitment, many papers do say that we should see a decrease in the dead space calculation. Next day, when the patient was put in prone, PF ratio is unchanged, compliance is unchanged, but the PaCO2 goes from 40 to 50, and end-tidal CO2 goes from 24 to 30T. We have an alveolar dead space calculation now that is 0.36, and if you remember, in the first one was 0.5. So with this recruitment maneuver, we see that we have a decrease in alveolar dead space. And if we look at some of the studies that I presented, especially with the Gattinoni one, seems that this patient has been recruited in the prone position. And this was one that was associated with good outcomes. Another disease that we see in that space ventilation is pulmonary hypertension. And we see a lot of that in congenital heart disease. However, I was going to focus on a congenital diaphragmatic hernia because here at PICCS, we take care of neonates with CDH. And so a birth defect that doesn't have a high prevalence, but is quite prevalent at PICCS because we're one of the centers that take care of very high risk CDH, and is herniation of abdominal organs into thoracic cavity, most common left-sided. And then the prenatal severities now is associated using observed to expected lung-head ratio. And so is isolated in 2/3 of the patients. The spectrum of disease is driven primarily by degree of respiratory failure from pulmonary hypoplasia, is the severity of pulmonary hypertension that result from vascular remodeling, but also like less cross-sectional area and cardiac dysfunction. And some historical perspective from PICCS is that at the beginning, this was classified as surgical emergency, but 3 major management transitions improved survival, and seeing it as cardiopulmonary disease rather than a surgical issue, so prioritizing heart-lung interaction, a deferred surgical approach, and gentle ventilation. So if we look at this term, infant observed over expected LHR is 33, which puts in moderate range, but close to maybe severe. And then there is another marker there of 35%, but current age is a 36-hour-old. The patient was on HFOV, MAPO 14, frequency of 10, amplitude of 50, and FIO 2.5, but has an acidotic gas that with a PaCO2 of 80. And so the problem with these patients is that they do not tolerate the acidosis very well and can precipitate an even higher PVR and pulmonary hypertension. And so sometimes what we see is that people here want to deal with the CO2 by increase and the severe acidosis by increasing the ventilation. However, here we have a dead space physiology, and in this case, rather than increasing ventilation of a lung that has pulmonary hypoplasia, the management strategies are related to decreasing the pulmonary hypertension by an NO, neuromuscular blockade, sedating, sometimes manipulating the SVR, and bicarbonate bolus in extreme cases when you have a pulmonary hypertension crisis because of severe acidosis to improve the acidosis. Another disease when we see that space ventilation is sudden pulmonary vascular occlusion. And I took a case of 15-year-old with nephrotic syndrome, intubated, recovering from sepsis, who, while weaning out the ventilation, developed sudden tachycardia, tachypnea, dyspnea, and hypotension with a PaCO2 that increases to 58, and end-tidal CO2 that decreases to 28. And if we calculate that, that space fraction is 0.5. But that pulmonary vascular occlusion can happen from thrombus. In this case, can happen from fat, femoral fracture, or air. The last one that has been described for having dead space ventilation is severe asthma. So in asthma, we have markedly increased airway resistance, pulmonary hyperinflation, high physiological dead space, hypercarbia, and dynamic hyperinflation. However, dead space calculation is not used in asthma in clinical arena. We use in asthma to follow the progression markers of dynamic hyperinflation, such as total exhaled lung volume, prolonged apnea that begins at the end of inspiration, and at bedside, the PIP, plateau pressure, and the ortho-PIP. But I did want to also take this case of asthma to highlight something else about that space calculation. So This is a 12-year-old with severe asthma, sedated and paralyzed on volume control. And so we have here tidal volume of 280, respiratory rate of 8, a minute volume of 2.2, and a PIP of 3, so low PIP strategy. And the intrinsic PIP of 14, plateau pressure of 24, and an end-tidal CO2 of 62. We have a blood gas that shows a PaCO2 of 58, and the alveolar dead space that is calculated here as negative. And so, can you have a negative dead space when your expired CO2 is higher than your PaCO2? Sometimes in severe obstructive disease, CO2 is transferred from the capillary blood to alveoli and can be trapped due to airway obstruction. So these alveoli, they fail to expel CO2 because of obstruction, will act as a reservoir. And when the stored CO2 is eventually expelled, and tidal CO2 does not truly reflect the PaCO2, but rather what CO2 has been retained in the alveoli. Another time when we see a higher peak, like end-tidal CO2, would be exercise, but that's not very relevant to clinicians like us in the pediatric ICU. And so to wrap up the dead space, there's many conditions that create dead space, pulmonary embolism from clot, fat, or air, severe asthma, pulmonary hypertension, and decreased pulmonary vascular flow, ARDS, high PIP and overdistension because of mechanical ventilation, or any low cardiac output state that decreases the pulmonary blood flow. And while we're wrapping up, I'm going to hand this over to Dr. Karthi, who is going to talk about the blood mid-air and now low VQ and shunt.
Thank you, Dr. Mema. So the scope of next few slides would be to have an understanding of applied physiology of hypoxemia, particularly low VQ, what we call as VQ mismatch, and shunt as a cause of hypoxemia in a disease like ARDS. And also a small case to illustrate how perfusion mismatch can affect your VQ abnormalities and cause hypoxemia in the end. Let's directly move to the case. We have a 5-year-old boy, Master V, who presented with the typical acute history of respiratory prodrome followed by hypoxemic respiratory failure. He came hypoxemic to ICU and got intubated within minutes of admitting into PICU. And that X-ray pre and post intubation shows bilateral infiltrates, no major changes. And at 2 hours of mechanical ventilation, he was on pressure control mode with reasonably high pressures, generating a tidal volume of about 6.5, the desired tidal volume. But his FiO2 still is at 70%. And we did a gas at 2 hours. The arterial blood gas shows PaO2 of 55. So this is hypoxemia, and he's still on 70% oxygen. And the saturation reads at 87, 88%. So this is a typical case of severe ARDS. And as a clinician, we generally calculate PF ratios and oxygenation index at the bedside. What we did for this case as well, which shows PF of 80 and OI of 22. So all of us know that from the definitions, this is severe ARDS. So at this stage, if we consider Master V to have severe typical ARDS with this textbook picture of alveoli, the question in our mind, based on physiological principles, what would be the most important cause for this hypoxemia in this child at this stage when he's still getting ventilated and on 70% oxygen? So if you look at the causes of hypoxemia, the 5 most common causes tabulated in most literature, we can straight away rule out hypoventilation and decreased inspired oxygen concentration, like high altitude hypoxia in this child, based on logic and he's on ventilator. But the calculated indices what we have had in our hand, the oxygenation index and PF ratio, does not give any information how to rule these 2 parameters. For that, we need alveolar arterial oxygen difference, which was spoken about in the first lecture by Dr. Naiber. I'll probably touch upon it, how it helps in differentiating these two conditions. If we see Master V's case, we are giving 70% oxygen, which gives us an inspired oxygen tension of 500, which is derived from the formula shown here. And if it enters alveoli, and the still arterial oxygen tension is quite high, it is lowered by the available CO2 in the alveoli, but it is still quite high, 440. But what we got in the arterial side is 55. So the difference between alveolar and arterial oxygen tension here is 385, which is very high. A high AADO2, the high AA difference virtually rules out your hypoventilation and low inspired oxygen tension. So the problem with calculating and relying on AAO2 is that it is heavily influenced by FiO2. So if our FiO2 is 70%, we get 385. If it is lower, probably we'll get a lower number. Although a higher number signifies that there is hypoxemia because of VQ mismatch or shunt, but it is not proportional to the degree of shunt because it is influenced by FiO2 at the clinical setting. So we need probably a better parameter, and people came up with ratioing it rather than the difference. So AA ratio, which is a fraction of oxygen entering into the artery as compared to what is available in the alveoli. So this gives a ratio in our child 55 upon 440, which is 0.13. So in health, at health, you generally transport about 75 to 80% of your oxygen available in the alveoli to the arterial side. But here what we get is about only 13%, which is very low, suggests that there is possibly hypoxemia due to shunt or VQ mismatch physiology. So this is probably a better indicator, and also it changes more predictably with FiO2. The problem with AA ratio is that you need a calculation. You need to calculate PaO2 from the alveolar gas equation, which is given here. So we know that the alveolar gas equation is heavily influenced by FiO2, also by PaCO2. But if you take only FiO2 and leave alone all other parameters, what we get is the PF ratio. So from AA ratio, more simplified version of AA ratio is what we are using at bedside, the PF ratio. What we calculated here is 80. And it's a good index. It changes predictably with FiO2, so it can be used for monitoring disease progress, as what we do in clinical settings. From mild to severe ARDS, we classify based on PF ratio. But the problem with PF ratio is that it does not differentiate the causes of hypoxemia because it does not take into account of PaCO2, so it does not differentiate hypoventilation or low inspired oxygen. So that's kind of one message here. So what we have seen so far is all the indices of hypoxemia, which are tension-based, which utilized either PaO2 or PaCO2, while content-based indices, which can be calculated from utilizing oxygen saturation, hemoglobin, and oxygen tension, would be probably a superior index. We know the oxygen content formula is depends on the available hemoglobin and saturation mainly, and a minuscule of contribution from the PaO2 here. So if we have the content of oxygen at 3 different sites, the mixed venous, the pulmonary end capillary, and in the arterial side, you would be able to calculate shunt fraction. We'll come to calculation of shunt in our index child in the subsequent slides. While most of the literature, physiological literature, supports content-based metric as a better index of hypoxemia because it takes into account the venous oxygenation or the mixed venous oxygenation in calculating the gas exchange or in understanding the gas exchange. In fact, the definition of hypoxemia should be based on content, as that hypoxemia should be defined as low or inadequate oxygen content rather than oxygen tension. That is a valid argument. So let's move on to our basic question. What is the most important cause of hypoxemia? So we can rule out based on AADO2, the two more objectively now. And let's move on to diffusion limitation. So there is an ample chance of this child to have diffusion limitation because of collapsed alveoli or poorly ventilated alveoli and increased thickness of the membrane. In health, if you see, our alveolar capillary membrane is designed for an excellent diffusion. The surface area is so big and it is perfused with capillaries with a large amount of volume and a good transition time. So it is the best membrane for diffusion. But in disease like ARDS, it's affected because the surface area gets reduced because of collapse and obstructed alveoli, and also the membrane thickness increases. But at the same time, if we see our Master V's case at this stage of the disease, where we are ventilating him and opening up alveoli and also giving 70% oxygen, which increases your AA gradient to a huge number. We have an alveolar oxygen concentration of 400 plus here, and the venous side it is about 40 to 50. So what you get is a gradient of 400 plus, which is good to overcome any amount of diffusion limitation. So supplemental oxygen is the most powerful way to eliminate diffusion limitation. And in most of the clinical settings, what our children gets about 40% or more FiO2, which is sufficient enough to rule out or remove diffusion limitation as the main cause of hypoxemia. So although it is theoretically important and important at the early stages of the disease, but when you are ventilating a child with refractory hypoxemia, probably diffusion limitation is not the main reason for hypoxemia. Then we are left with two big options, the low VQ and shunt, which are kind of a spectrum of the same disease. Shunt is an extreme low VQ, where the VQ is 0. Let's start with low VQ. Is it a cause of significant hypoxemia at this stage when we are ventilating him at high pressures and high FiO2? If you look at the alveoli with a typical alveoli of low VQ, this is a textbook diagram of low VQ, where your ventilation is reduced in 50% of your alveoli, and the other 50% is getting normal ventilation, or probably getting higher ventilation because most of your tidal volume goes to the well-ventilated alveoli. Then if you are breathing room air, your PaO2 at the normally ventilated or hyperventilated alveoli will be normal or slightly higher. That gives us an oxygen content of about 20 from this oxygen dissociation curve. And the poorly ventilated alveoli, although it gets some ventilation, but still it has a low oxygen tension in the alveoli, which is, let's say, it's 45. And when these two blood gets mixed, the content would be the arithmetic average of what the content you get in the capillaries of both these two alveoli, or the 50% alveoli. And from 20 and 15, we get an average of about 17.5. That is the mean content. And that in turn gives us a saturation or a PaO2 of 70 millimeter mercury. So one thing we need to remember here is that the PaO2 at the arterial side is determined by the content, not by the mean value of PaO2 of different alveoli. It is the content of different alveoli which gets averaged in the arterial side, and from the content, using the oxygen hemoglobin curve, we calculate or we derive PaO2. So the PaO2 is low. A child will be hypoxemic when he breathes room air, when he has 50% of alveoli which has low VQ. But what happens if we give supplemental oxygen? Let's say in Master V's case, we give 70% oxygen. We increase our inspired oxygen concentration to 500, which will become 440 in the alveoli, or slightly higher if he is getting a VQ of more than 1, probably 440 to 5, anywhere between 440 to 500. So the content of oxygen from this alveoli in the capillary side would be 21, not very high from the 20 what we get because of the nature of the oxygen hemoglobin dissociation curve. Even if you have a very high PaO2, your content will not change much. Probably it will rise by 1 or 2. So, but what happens to the poorly ventilated alveoli if we give very high FiO2? Instead of 45, we get a better alveolar oxygen concentration, even if the VQ is lower. So even if it reaches close to 100, your content will rise from 15 to 20 here, and the overall average content would be 20, and your hypoxemia is mitigated. So in a low VQ region, if you do very high FiO2, most of your alveoli get a very reasonably higher concentration of oxygen, and which in turn converts your hypoxic blood into probably normal oxygenation blood at the end capillary level, which relieves or mitigates your hypoxemia. So that's one important message here. So if you see, if your VQ ratio is, even if it is 0.1, a 50% oxygen would correct your hypoxemia and improve your content to a normal level. And even if your VQ mismatch is very low, if your ventilation is very low to 1/100th of what you get, if it is 0.01, and 95 or 100% oxygen would still relieve your hypoxemia because of low VQ region. So that's one important message here. And we also focus on CO2 here. So although the low VQ region has higher CO2, the normally ventilated or hyperventilated alveoli compensates for the increased CO2 on the other side. And eventually what you get is probably reasonably a normal CO2. So a PA CO2 is largely unaffected because of two reasons. One, the normal alveoli or normally ventilated alveoli takes care of the CO2 exchange because CO2 diffuses very well. Also, most of the patients with hypoxemia will have hyperventilation, which also improves your minute ventilation, or you will be ventilating them with a reasonable minute ventilation on your ventilator. So generally CO2 is not a problem in a low VQ situation. So the bottom line or the answer to the question of VQ mismatch in our index child probably is less significant as a cause of hypoxemia when you're giving 70% FiO2, because it corrects your hypoxemia even in low VQ regions. But still, in the clinical setting, you're not going to give a very high FiO2 to mitigate low VQ because oxygen is toxic. We have ways to improve low VQ by recruiting more alveoli or improving VQ matching by giving drugs or administering nitric oxide. Then we are left with shunt as the final option for refractory hypoxemia in our index child. How it operates, again, we go back to the same diagram. In room air, the shunt behaves in a similar way, but it is a complete obstruction. There is no ventilation happening at all. So you'll have oxygen content in the normally ventilated alveoli at normal and poorly ventilated alveoli at low, and the average is lower, and you are hypoxemic when you are breathing room air when you have 50% of shunt. But when you give a high FiO2, what happens? You will increase PaO2 in the normally ventilated alveoli, likewise what happened in the low VQ region. Your content will not increase so dramatically, it will increase only marginally, but the poorly or non-ventilated alveoli will not get any oxygen and the content will remain still low. Even if you give very high FiO2, even if you increase your PaO2 to 500, 700, your non-ventilated alveoli will not increase their content, oxygen content at the end capillary level, and you will still be hypoxemic when you have high degree of shunt. If you have a very low proportion of shunt, if your shunt fraction is 20% or less, like what we have seen here, if you increase your FiO2, maybe the additive content increase, even if it is minuscule, eventually marginally improve your oxygenation content in the arterial end. But if you have a very high shunt fraction, especially if your shunt fraction is 30% or more, no matter what, if you increase your FiO2, even up to 100%, you will not get any increase in PaO2 because the non-perfused alveoli will not be able to raise your content of oxygen at the end capillary level. So eventually you will be hypoxemic even if you are breathing 100% oxygen. And we also focus on CO2 here, which Dr. Mema has explained very well in her dead space calculation. So if we have a very large shunt, a large amount of alveoli are not participating in gas exchange, then your PaCO2 remains within alveoli, high PaCO2, but the one which is participating in the ventilation will have low CO2. So what you get at the end tidal level is low CO2, but what you get at the arterial level is a high CO2, and you will have a very big gap of arterial and end tidal, and eventually leading into overestimation of dead space. But it's a good thing that if we know that the dead space is very high, possibly you will have a very high shunt fraction in a pulmonary parenchymal disease. That's one inference. So if we know that shunt is, if we understand in our case, shunt is the predominant cause of hypoxemia, how are we going to estimate it? I'll quickly go through the main three main causes of hypoxemia or deoxygenated blood mixing into the arterial side is that diffusion defect, low VQ, and true shunt. And in a clinical setting, diffusion defect is less meaningful because we will be giving supplemental oxygen. Eventually, the reason for venous admixture, which is defined as the amount of mixed venous blood to be added to the oxygenated blood to cause the resultant hypoxemia, is because of two reasons: low VQ and true shunt. So if you read physiology articles and textbooks, you will come across this term venous admixture, which is a representative of physiological shunt contributed by low VQ and true shunt. We know from the previous discussion that if we administer 100% oxygen, we can convert low VQ region into an oxygenated region. So if we administer 100% oxygen, what we are left with true shunt, and what we are calculating as venous admixture when we are giving 100% oxygen is the true shunt. And it goes by the equation which requires three different oxygen content calculation at three different sites. One is arterial blood, which we can get from ABG. And we also need a mixed venous blood, which we can get from central venous catheter. We don't do pulmonary artery catheters anymore in the clinical settings most often. And we also need end capillary oxygen content. So we'll see how we can calculate for master V or shunt fraction. So we did a blood gas after increasing our 100% oxygen from 70 to 100%, and we got a very marginal increase in PO2 from 55 to 60, and his hemoglobin was 12.5 at this stage. And we also did a mixed venous gas. He has a IJV line, so his venous saturation is 65, and the oxygen tension was 40. And we input all these numbers here. So in the venous side, we have a hemoglobin saturation and venous oxygen tension. And in the arterial side, we have hemoglobin, SaO2 was 90, PaO2 was 60. And for the capillary side, what we have is the same hemoglobin. And we know that saturation is 100% here because it is fully oxygenated blood. And for calculation of partial pressure, we extrapolate it from the PaCO2. So we are administering 100% oxygen, where our inspired oxygen concentration is probably 700 from the alveolar gas equation, and which will become 650 here. So we take this 650 as a number for in capillary. We input all these numbers in the content calculation, and we get an oxygen content of 19 at the capillary side, 15 at the arterial end, and 11 at the venous end. And eventually we got a shunt fraction of 45%. So what does this mean? 45% is probably reasonably a high shunt fraction. We know that anything more than 30 is probably a very high shunt fraction. But can we do anything about it? How are we going to treat it? That's the next question. Although it's a true shunt, it still can be treated. Even if you are not able to open up more alveoli to mitigate the shunt. By giving PEEP, you can also reduce the VQ mismatch by decreasing the perfusion of unventilated lung. This has been proven in several physiological studies, is that if you apply PEEP or titrate PEEP, it can even decrease the perfusion of unventilated lung or a shunted alveoli, and thereby improves VQ matching, and it may improve your oxygenation. Same is true for prone position. Prone position can also improve true shunt by improving or reducing the shunt fraction at the dorsal lung without concomitantly increasing the shunt in the ventral region. So again, physiological study shows that prone position works. Also, nitric oxide may be controversial in a true shunt, but still there are some of the case reports, emerging reports from the EIT studies shows that it can also decrease shunt fraction in addition to VQ matching by acting on non-perfused alveoli. So all these strategies for refractory hypoxemia can be employed even if there is true shunt. And if the shunt fraction exceeds 50 to 60%, the best way to improve oxygenation is to improve the venous side of the oxygen content. And we know that one of the best way to improve venous side of the oxygen content is VV ECMO. That's what we resort to when we have very high shunt fraction. Generally, people resort to ECMO. when it goes beyond 50-60%. Finally, a word about perfusion mismatch causing hypoxemia. So this is a case which we recently had. A young infant presenting with RSV pneumonia with a typical viral pneumonia-like picture. There is a good amount of aerated lung here in the X-ray, but what we had in the gas was severe hypoxemia requiring very high FiO2. We trialed all these measures for adjuvant therapies for improving oxygenation, but there was only marginal improvement, and the shunt fraction we calculated here was 48%. So can this happen with a mismatch of anatomical versus functional shunt? Anatomical shunt meaning by non-aerated lung regions in the CT, which is a lower amount as compared to a calculated shunt fraction, which is very high. We got this insight from COVID studies where it can happen, particularly in COVID. People encountered a kind of happy hypoxia, which is explained by a mechanism primarily perfusion related. You can have probably pulmonary embolism-like phenomenon where there are microthrombosis and perfusion defect. Also, there is a reversal of impairment of hypoxic pulmonary vasoconstriction, where generally your dorsal non-ventilated lung should get a lower amount of blood because of hypoxic pulmonary vasoconstriction. If it gets impaired, then you will end up in severe hypoxemia despite your lung being looking better in your chest X-ray. So that's one thing which we need to consider in mind. So in summary, low VQ and shunt are the common cause of hypoxemia in clinical settings. And when we administer high FiO2, we probably overcome our diffusion defect and low VQ. What we left with is true shunt, and it can be calculated with arterial and central venous blood gas, and perfusion mismatch can also result in hypoxemia. Thank you.
Thank you.
Thank you very much. That was a very informative and very concentrated talk. And we have lots of questions, a big list of questions from the audience, which we need to address. A lot of things have been covered and very nicely explained everything. Do you want to summarize anything, Dr. Karthi, in few words? Do you want to just summarize in the end? Any takeaway, or shall I just start with the question answer?
I think in the interest of time, you can start with probably the summary is that the extreme mismatch and there can be different rates of mismatch as well in the clinical settings.
Right. So I'll start with the question answer session. Myself and Dr. Milind will be taking the questions and asking. So the first question is, what is the significance of calculating alveolar dead space in terms of predicting prognosis?
Yes, I gave some of the studies that has been, especially in adults in ARDS, that the dead space, calculation of the dead space and high dead space is actually related to poor prognosis. And the first one was the Nukton study in 2002, and has been multiple studies like along the same line of evidence that high dead space, calculation of dead space is actually related to poor prognosis. Thank you.
Doctor, I think the recent study by Bhalla et al. And earlier Gattinoni. The next question is to the PICCS team, madam. Do you use volumetric capnography and VD by VT estimation routinely in your PSU? Is it a routine doing a volumetric capnography in your unit?
No, we do not use volumetric capnography, and that's why I use the time-based capnography. And I didn't focus on the volume-based capnography, but I'm happy if someone wants to share from their own experience. We do not use it here.
So the question was whether this is superior. Is it superior to, time-based capnography or ventilator ratio?
Definitely. Volume capnography is definitely superior to time-based capnography. However, not all the ventilators well calculated, the ones that we have done, and so that's why we resort to the time-based capnography.
All right. The next question is, are all antenatally diagnosed congenital diaphragmatic hernias electively intubated at birth in your center?
Yes, generally all of them are intubated unless congenital diaphragmatic hernia shows very little respiratory distress. But and great saturation and great CO2 exchange. And in general, in those cases, you would just put an NG tube and try to suction the gut. But we are a center who deals with very high risk because we're connected to a hospital that has neonatology, and that's where high-risk deliveries are. So that case of not intubating and ventilating would be very rare.
So there is a question where the audience wants to ask, is it reasonable to keep the PEEP that low? In one of the cases where the PEEP was 3, while
Intrinsic PEEP.
intrinsic PEEP is 14.
That was the asthma case, and we're getting now into ventilation of asthma. And so the idea behind the PEEP of 3, and I took that from that recent paper of the Italian colleagues. The rationale behind it is that you, with an increased PEEP, you are reducing the driving gradient during exhalation. However, there are a lot of data that shows that it's only that you will impact that when your set PEEP is close to 80% of your intrinsic PEEP. And there are some cases when actually increases the PEEP paradoxically is going to decrease your auto PEEP, and that's when you open airways and allow air exhalation. That is another topic on its own, and I love mechanical ventilation of asthma, but there are several PEEP strategies, and in this case, they chose a low PEEP strategy because they were worried about what is the driving gradient during exhalation, because when the patient is sedated and paralyzed on volume control during inspiration, you're going to get that air in no matter what. And so you only worried about exhalation, and a sedated paralyzed patient, you don't have to worry about that inspiratory effort.
Okay, thank you. So it's a well-known thing that there is a lot of auto PEEP or intrinsic PEEP in these kind of situations. So Dr. Mema has covered it very well. So next question is, in case of moderate to severe ARDS, there can be a mixed situation of shunt plus diffusion problem. If there is a poor response to 100% FiO2, why is it always due to only shunt problem? Dr. Karthi,
yeah, so,
yeah,
as I explained, the pathophysiology is that you will get all 3 reasons for hypoxemia. That is definitely the case in ARDS. But when you're already mechanically ventilating, again, I'm illustrating this case where this child was already mechanically ventilated and on a high pressure setting and on a high FiO2. So we have reached a stage where there is a refractory hypoxemia. So when there is refractory hypoxemia, especially to high FiO2, the main reason operating would be shunt rather than low VQ, because as I explained, even a very low VQ would get a reasonable oxygenation when you have very high FiO2, when you increase your alveolar oxygen concentration to 400, 500 with a very high FiO2. And obviously diffusion defect can be easily overcome because the gradient is such that it is so high that most of your diffusion defect as the reason for hypoxemia would be overcome with high FiO2 as well.
Yeah. Okay. So next question, in pulmonary hypertension, does shunting also add to the troubles in later stages, is what she wants to ask.
Yeah, so in pulmonary hypertension, it does. And sometimes you, for example, in congenital diaphragmatic hernia and very bad pulmonary hypertension and high PVR, we actually keep the PDA open because we sacrifice saturation for not failing the RV. And so in those situations, you have a high degree of shunt that is going through the PDA, but sometimes many children also have a PFO, and they would have intracardiac shunt when the right-sided pressure go higher than the left-sided.
All right. Next few questions are, I think, already answered, so I will just quickly read through. The one question is, with the improvement in dead space, the PaCO2 minus EtCO2 difference reduces. In that case, do we expect EtCO2 to increase? So, of course, the answer is yes. And then the next question is, why is severe shunt hypoxemia refractory to 100% oxygen using the idea of blood mixing? I think this has been explained in the lecture, but do you want to again talk about that?
So yeah.
Yeah.
So basically, if it's primarily because of the function of the oxygen hemoglobin dissociation curve, even if your normally ventilated alveoli gets a high PaO2, still the oxygen content will not be increased at a greater magnitude because your saturation goes only up to 100%. And you can't go beyond the 100% saturation. And the content is calculated from predominantly contributed by your saturation. So eventually your content would not go very high, and you will end up hypoxemic. The non-ventilated alveoli will not contribute anything. So you continue to be hypoxemic if you have shunt. Yeah.
Next question is it not useful to monitor the PaCO2 and EtCO2 gradient as a surrogate for dead space as to measure to monitor the effectiveness of bronchodilator therapy in intubated asthmatics?
Yeah, so it's not used actually because, and I haven't seen any study who showed a very good correlation with that, because other markers of dynamic hyperinflation are much better at showing you the response of bronchodilator. Is the difference between your PIP to your plateau pressure, because that's only to overcome the resistance. Is the plateau pressure itself, because like asthma shouldn't be a compliance issue unless you're very overdistended and then you now are affecting compliance, and is your intrinsic PIP. Those are much better markers of showing where response to bronchodilators and the reducing dynamic hyperinflation.
Next question is, what is the role of altitude on P capital AO2, that is alveolar oxygen partial pressure, and P small AO2?
Okay, yeah. So if you're in high altitude, naturally your inspired oxygen FiO2 would be 21%, but your PiO2, the partial pressure of inspired oxygen concentration, will drop because your atmospheric pressure drops from 760 to whatever high altitude you are in. So eventually your alveolar oxygen partial pressure will drop, and which will be similar to arterial side. So you will not have a gradient or the difference between alveolar and arterial partial pressure, but both your alveolar and arterial partial pressure will be low if you climb altitude.
Okay. So next question is, in case of moderate to severe ARDS, there could be mixed situation of shunt plus diffusion. I think this is done already. So another question, why do adult intensive care people still use?
No, there is a question, how do you interpret ventilator ratio?
Yes, there is one more question. So how do you interpret ventilator ratio? Is assessing AVDSF not enough, and is ventilator ratio a superior parameter?
So I didn't put the studies for the ventilator ratio, right? But that is a practical, like straightforward to estimate ventilatory efficiency. because you have the minute ventilation, you have the body weight, and then you have your ideal PaCO2. And so the numerator is the actual ventilation requirement that produces the measured PaCO2, and the denominator is the theoretical ventilation needed to maintain the normal PaCO2 37.5 that is in the formula. So if you have more than one, you have impaired ventilator inefficiency. And the more inefficient the ventilator, the higher would be the VR value. There are some studies that show that this is a very good marker of following like the dead space.
Okay. So there is a next question as I was asking. Why do adult intensive care sites still use the PF ratio in diagnosis and severity stratification of ARDS, while in pediatrics we still use OI?
I think I purposefully did not cover this because we discussed this at length in the last lecture by Dr. Naiber. So what his answer was, I probably reciprocate. The reason for us using oxygenation index is that pediatricians are still little PEEP hours or PEEP kind of, we don't use as much PEEP as how adult intensivists use. So we still have probably room in adjusting our mean airway pressure. So to take into account of our mean airway pressure, in addition to PF ratio, for determining the severity of ARDS would be probably more relevant in pediatric population as compared to adult. That's kind of the answer why our guidelines still use oxygenation index and adults.
I feel the reverse actually, because in adults they use higher PEEP, so they should be more worried about impact of mean airway pressure and OI. We use lesser PEEPs and still we are worried about OI. That's the problem. And if you see Eolia trial and their criteria for using ECMO at PF ratios, and most of our patients, if you use OI, we tend to think about ECMO at much higher OIs when the PF ratios actually can be much lower, but OIs are not that high because our PEEPs are lower.
Yeah, if you max out your mean airway pressure, then probably you're not going to change your mean airway pressure anymore. Then your PF ratio will become a determinant of your kind of severity of the disease. So that's kind of easy for adult world because they already are ventilating at very high pressures. They are not scared of giving very high pressures. While for us, our PF ratio would be different if I'm giving, if I don't want to increase my PEEP from not more than 10, and someone is ventilating at 15 who get a better OI, while I'll probably get a higher OI because I'm not applying enough pressure to open up more alveoli. So in this case, probably if my OI is higher, probably I will relook at my MAP or ventilation settings and probably change my strategies. So that's probably one reason why OI discriminates better or probably gives more information in us.
I mean, OI of course discriminate better because you're using all the parameters that what you're using in terms of oxygenation for what you're getting. And there is less variability on how PEEP and mean airway pressure is used in adult and more variability of how it is used in pediatrics. That's the summary. But yeah, for us, a better indicator, you're using much more. You're using what am I using and what am I getting?
Yeah.
So another question, how is VQ mismatch predicted in post-lobectomy cases? As one may not be able to predict how much of the lung has been removed. So
I haven't really thought about it, but yeah. Yeah. I mean, if you calculate in the model, like what we have shown, it is just a very simplified approach. What I have taken is 2 or 3 unit model of a whole lung, but in the same lung you have different regions of PQ low VQ, shunt, and even pulmonary embolism-like phenomenon.
Dead space.
Yeah, dead space. So it's a complex kind of number, but what you get is a simplified number. Eventually, how we are going to use it is probably to prognosticate rather than dramatically change any of our management strategies.
Okay. The next question is, will increase in the positive end expiratory pressure help if shunt fraction is more than 30% when increase in FiO2 has failed to improve oxygenation?
Yeah, so that's what I showed from several physiological studies, and naturally that's what we do in clinical practice as well. We don't calculate shunt fraction at the bedside for every case, but in refractory hypoxemia, we still play with PEEP, titrate PEEP to get an optimum PEEP. And the physiological reason for increasing PEEP to improve oxygenation, even in true shunt, is that it can decrease your perfusion in the non-aerated alveoli and improves your VQ matching, and thereby probably directs blood to a more ventilated, better ventilated alveoli and could help in oxygenation. So even in a true shunt with a high FiO2, you can still try PEEP or higher PEEP or PEEP titration.
How low can low PEEP in bilateral pneumothorax be used? Now
I think in bilateral, like, I
Good.
don't understand that question very well, because in bilateral pneumothorax, you may have to reduce the pneumothorax, and it depends what caused the pneumothorax, right? So it's a question that is answered that is related to the context.
Yes. Next question is, does inhaled nitric oxide help to improve VQ mismatch?
Yes.
Yeah. So it does, at least theoretically, it definitely should, because your nitric oxide goes into a better ventilated region, and it's going to improve blood flow to the better ventilated alveoli, eventually improving your VQ matching. But different units use different doses.
Some of the initial physiological studies show that the better response is with low NO, like, around 2 to 5 parts per million, rather than higher doses of 20 parts per million. Because in PBR, you have like a dose response curve, and in VQ mismatch. As in our unit, we use about 2 to 5 parts per million. But one thing about response to NO in VQ matching is that NO is only going to reach those alveoli that are ventilated. And if those alveoli that are ventilated are very few, then you're not going to have a good response. So one thing that we do before starting the NO is like recruitment maneuvers and recruiting the alveoli, so that then we can improve the VQ matching.
Okay. What ppm you start, ma'am? If you have a child with ARDS with refractory hypoxemia and you want to start inhaled nitric oxide, generally from what ppm you start?
So it depends. Like, if we have an ARDS with hypoxemia, we do a sustained recruitment or decremental PEEP study, but we here use EIT to find the optimal PEEP. And after that, after having found the optimal PEEP, doing recruitment maneuver and having found an optimal PEEP, then if we're still hypoxemic, we would start the NO, and of course we would prompt the patient.
So you start with a 20 ppm, 10 ppm, what you need generally?
The NO you mean? I thought PEEP. No, for VQ matching, we start with 2 to 5.
Only 2 to 5, that's it?
Yes.
Oh, yeah. Nice, very nice, okay. Next question is inclusion of shunt fraction and dead space in severity of ARDS. That's it. There is a question mark.
I think we spoke about that, right?
We already spoke. Then the routine use of nitric oxide in ARDS when indicated. This is also discussed. If patient has FiO2 of 70% and still there is hypoxemia at that time, what would be the first thing to do, PEEP or FiO2 further, or prone positioning to overcome further hypoxemia?
It depends on the clinical situation and the child, but as we have there are options you can choose depending on what stage of or what type, what ventilator setting you are already on, and what you have already done, and which is working or not working. But all these are options.
Yes. Now, next question is, will shunt fraction be will be reliable if the patient is not on 100% FiO2 ventilation?
As I said, if you're not giving 100% oxygen, or if you're at low FiO2, then your calculated shunt fraction includes low VQ as well. So it's not a true shunt, it's a physiological shunt because of both shunt and low VQ. And to eliminate low VQ, you need to give a very high FiO2.
I think that was the last question. We finished our question answer session or a quiz round. So over to you, Dr. Milan.
Yeah, thank you, Doctor, for answer. And I would like to thank Dr. Mema and Dr. Karthi for this fabulous and very interactive session. It's been a great learning from both of you, and people always are interested what we have understood through this pediatric respiratory critical care series. They're very much happy to learn case-based scenarios and case-based interactions and interactive sessions like this. So I would like to thank once again for accepting the invitation to speak on this topic, and it was a great learning. And with this, I would also like to remind everyone about our next session, which is on the topic the lung as a spring, which will discuss about the compliance, resistance, and work of breathing in children. And it is going to be taken by Dr. Alberto Medina, who's the associate physician, and he has done a lot of work in this respiratory critical care, and it would be a great interactive session once again. So the date for
19th
this
August.
is 19th
19th
of
19th March.
March.
Yeah.
And timing also would be the same. And I would invite you all to once again join us, and it would be a great learning, I would say. Thank you once again. Thank you to all my colleagues, and thank you, Lorenzo. And at the end of this, we all shall get a survey link. I request you all to kindly fill it. Thank you so much.
Thank you so much.
Thank you
Good night.
all. Thank you
Good
for
night.
the
Thank you.
invitation, and hi to all PICCS alumni online. We're always very proud of all of you. Thank you.
Thank you, Dr. Mema. Dr. Karthi, thank you.
Great work. Thank you so
Thank
much.
you.